Good afternoon, everybody. This is the ePrescribing Masterclass. It's just gone 1 o'clock, and I can see that still people are joining in. So we're just going to give it a minute or so people can settle, and then we're going to kick off with our program for today. For now, I'm just going to put myself on mute. Welcome. Okay, it's 2 minutes past 1, so we're just going to make a start. Welcome to this masterclass. The masterclass is a work from NHS England where we bring together trust specialists to celebrate digital innovation. We can share our successes here on this platform, share learning and experiences around digital transformation. And the purpose is really for others to follow into the footsteps. Sometimes we've got national specialists from NHS England coming to speak. And today we've got 2 teams coming to speak, which I'll introduce shortly. Let me just introduce myself. We are the Chief Pharmaceutical Officer's Clinical Fellow this year. So this year for 12 months, we're out of normal practice and we work in the Transformation Directorate of NHS England, and part of our role will be chairing these masterclasses for you guys in the next couple of months. The setup for today, we'll have Aldrico speak first. I'll do intros in a minute. After his session, there'll be a Q&A if time's allowed, so Aldrico can come in and answer some of the questions you might have. And then we'll do the same thing with the University Hospital Birmingham. So we've got a trio that Amna will introduce for us. So please use the question tabs to ask any questions you might have. It's just good for learning and promote thinking. So I think next for me is to introduce Aldrico Velasco. It's a pleasure for me to introduce him to you. We met at a Digital Future event by the Skills Development Network earlier this year in Loughborough. He has a nurse background. He qualified in the Philippines and relocated to England in 2019, and he's done different roles since then. He's got an interest in nurse informatics, learning and development, and a special interest in research as well. Of note, he's a Topple Digital Fellow from the 3rd cohort, and I think he's done really quite well over the past years. Especially, he was finalist 2 successive years for the Nursing Times. So in 2022, he was the finalist in the Nursing Times for Overseas Nurse of the Year. And then this year, he was finalist at the Nursing Times for Diversity and Inclusion Champion of the Year. He's a clinical safety officer at the University Hospital of Derby and Burton at NHS Foundation Trust. And he's here to speak to us about e-handover at the Queen's Hospital Burton. I think I'm going to just hand over to you, Aldrico.
Thank you very much, Hoyen, and good afternoon, everyone. Again, my name is Aldrico. Thanks for that lovely introduction. And today, I'm going to take you to what I call a journey towards the recent implementation that our team has done specifically in our Queen's Hospital Burton site, and actually that includes 2 of our community sites, which is the Samuel Johnson in Litchfield and the Sir Robert Peel Hospital in Tamworth. In terms of the nursing e-handover, when you talk about a journey, it's probably best to give you a bit of a background of how we started a few years back. I think, at least in Queen's Hospital side, we're very lucky. We have a quite mature digital culture, if I can put it that way, because since 1990s, if I'm not mistaken, we are already using an electronic patient record, very early phase of the electronic patient record. So introducing something digital to the site is a blessing of some sort, because we don't have much challenge of immaturity or digital immaturity for staff. So next slide, please. So we only implemented the e-handover almost 4 weeks ago. So technically, we're still in what I call the honeymoon phase of our implementation, and we're still digesting a lot of feedback from the clinical area. We also continuously challenging ourselves based on the feedback, and there might be questions actually that we haven't asked ourselves yet. And by the end of this session, probably you will be asking questions that I probably don't know the answer just yet. But hopefully, throughout the next 15 minutes, I should be able to share with you the journey, focusing on what went well on that implementation, some of the best practices, some of the preparations that we did, and also share with you some of the challenges that we encountered and how we try to address them throughout the implementation. And lastly is what's next for us, given this initial implementation. Next slide, please. So before we go to those 3 focus of the discussion, I'd like to take you to our whys. I call that our whys, or the reason why we're doing the e-handover, why we've done the e-handover. So starting with data security. So way back, the way handover works is that it's very manual, which means nurses will go through the patient record, write the details that they need to hand over to the staff manually in a piece of paper with a pen, and then facilitate the handover. And the handover normally takes around 30 minutes to an hour during the time, years back. And our chief nurse back then has recognized that it's not efficient, it's not probably the best way to do it. So they tried to come up with a way on how to sort of upgrade that process. And they ended up with a Microsoft Word in a shared drive. Well, everyone can actually put some updates to the patient. So that Microsoft Word has an updated list of the patients, and every day, every shift, actually, nurses will need to update the relevant information for the patient on that piece of documentation. So that process has gone through so many years until last month, when we decided that we need to make changes as to how we actually, the way we do our handover. So data security is an issue, because obviously if that document just resides in a shared drive, everyone can get access to it, everyone can view it. There's no record as to who's viewing the information, who's making changes to the information. And I think that goes to as well our second one, which is about auditability. So if someone changed the record, delete the record accidentally or even intentionally, there's no way for us to know who did it. Efficiency is another main reason, because as we all know, we manually type in all the information from the patient's record to all of the interventions, cases, scenarios that we need to hand over to the staff or to the next ward, actually. And we feel that doing this actually takes a lot of time as well, while having a single piece of document during handover actually reduce our time from probably 30 minutes to an hour to just around 15 minutes to 30 minutes now. We still feel that there's so much opportunity in streamlining the process, making sure it's easier for nurses to update the information. And lastly is consistency. And throughout the hospital, each wards would have different way of doing their handover. And it can be tricky, especially if we try to move patients around. There is a risk of losing a very important information about the patient. That's why we want to ensure that our handover is consistent. It's got every essential information the patient has that needs to be handed over to the next area. So these are our 4 whys. Next slide, please. So what went well during the implementation? It's a 3-week implementation. And instead of a big bang approach, we actually went to, I will call it a divisional approach of implementation, wherein we started with a certain division, which is a division of surgery, and finish it with a division of medicine. So what went really well during that time when we were first starting is the top management endorsement and support from the senior leaders. And I think when you implement a change, especially a change to a process that's been embedded for years, the biggest buy-in, it should be the managers actually should be able to agree that it's the best way to move forward, because they will be the same people actually who will disseminate this information to the rest of the staff. That's why making sure that they're involved, making sure that we've got their support is an essential aspect of our deployment. Next one is communication and training. In terms of communication, we try to use all the medium possible to make sure that the ward is aware that this change is coming. It's very easy for the staff in the clinical area to actually overlook, let's say, an email announcing that a change is happening. So what we did is actually created posters, use social media, use our comms team to make sure that all avenues are covered in terms of informing the staff that a major change is coming to the handover process. Training is another aspect, and here we offer different modes of training. So e-learning is a main mode of training, and that's probably the easiest way that staff can access the training whenever it's convenient for them. But we recognize that not a lot of staff prefers this kind of mode of training. So we also made sure that our cells are available to conduct a training on the ground while in their clinical area, and making sure that we provide all of the training materials to them in different modes as well, either in a crib sheet or we send it electronically. So that way we are assured that by the time of deployment, we have a certain number of staff percentage that's trained to the process. And we're very proud to say that when we deploy the process, at least 80% of staff for each ward we deploy the system to has been trained to the process. Next one is the prep work, including the wards and trials. So this means that in advance, for a couple of months, we actually have certain wards, 1 or 2 wards, that's trialing the process. And that way, we can certainly look at the opportunities, get valid feedback, and address some of the issues that the ward has got in terms of the handover itself. Consistent rollout support is another thing that we've implemented, which means that that 3-week period, we made sure that someone is doing floor walking or a team is doing floor walking, going to the clinical areas, training staff on the ground, coordinating with system support for access, and ensuring that everything is running well. Partnership is another thing, which means that we have a direct link to our system support team, which means that as soon as we train the person on the ground, our system support team can create the account directly. So that's a special link that we built to make sure that the deployment will proceed as smoothly as possible. And lastly is a strong digital culture. Like I mentioned, Queen's Hospital has been using an electronic record since the 1990s. So people are sort of open to digital change and actually embracing digital change, which we're very lucky about. Next slide, please. In terms of the challenges, the first one probably will be about the flexibility of the application. So I think that the right term is we were caught off guard in terms of the limitations of the application. So this means that depending based on the feedback on the ground, we normally take that feedback to the supplier, and then we ask them to make some changes based on the feedback. But unfortunately, those changes are not possible. Even a simple change as adjusting the column, changing the font size of the handover, those in itself are not possible. So I think we find it really challenging, especially if that change, it sounds simple actually, but it can produce a really positive impact to the staff if we can manage to implement those simple changes. Next challenge is teams with different approach to handover across the trust. So a certain ward would have very niche information or very specific information that's only available to them that may not be relevant to the next ward. So I think we find it challenging in sort of consolidating and having a standard approach to make sure that when the patient moves from one area to another, that information gets carried across as well, because that's another advantage of this handover. Since it is electronic, when the patient moves from one area to another, that information goes with them too. But the question is how relevant that information is to the next area. Use of secondary system is another challenge, because the handover is a separate system from our main EPR, which means obviously the ward has to remember another set of username and password. That the ward needs to click on a different link to access the app, and some way it's an extra work for them. And lastly, so there's still some level of manual input. I think the direction is to make sure that the handover will extract all information directly from the main system to the handover itself to reduce manual input as much as possible. But at the moment, there's still a big level of manual input that the staff need to do in it. And as we all know, if there's a level of manual input, that means there's some level of error there that can happen as well. Next slide, please. So what's next for us? So I think the first thing is the handover standardization. It can be a massive thing, a trust-wide thing, wherein we need to work with the clinical areas to really understand and set with them what information do we want to see in the handover. We did it previously, but after we deployed the system, that's where new feedback came in, and that's where we realized that actually the work in standardizing the handover is not done, and we need to continue the process. Next one is the MDT approach to handover. It means how do we involve the other teams, a multidisciplinary approach to handover. At the moment, this is very useful for nursing, but what we want is to be able for other teams like the AHPs or even the doctors to have some input to it, to be able to access it based on how they can use it effectively. Next one is better system integration. This is where I mentioned that we want to try to remove as much manual input as possible, because we want to extract information directly from the main system. That can save time, and that will make sure that the information is up to date as well. And lastly is accessibility. We want to make sure that the handover is accessible regardless of the profile of the user using it. Even if you're, for example, very much adept to technology, you have eye and visual problems, you want to make sure that that handover is accessible for you. Next slide, please. So as a summary, I think I can just say three things at the end of the session. First one is to understand and really appreciate your whys. And I think this is something that it took us a while to really pin down. Why have we done what we did? Obviously, there are still opportunities there, even after we implemented the application, but it's something that we will try to work on moving forward as we continue to develop the application. Next one is setting the scene, making sure that you actually make all the preparations as much as possible, from getting the buy-ins of your executive to actually writing the roll-up report. Everything that happened in between should be able to have a good insight of that. And lastly is sharing and learning. So that's the reason why we also took advantage of this opportunity to share what we did to everyone. It's because we know that in return we'll also learn from some of your questions, from some of your feedback, because we appreciate that what we have is not a perfect system. It's far from a perfect system at the moment by the looks of it. But we are still proud of what we did, because we know that we are actually addressing some worldwide. There's still benefits to it. And we know that it's a journey, and we just keep on improving what we've so far completed in this implementation. And I think that's the end of my presentation.
Thank you for that, Aldwig. I really enjoyed your presentation, really clear slides as well. And it's nice to hear from digital mature trust that's a bit further along the path so others can learn from it. You've given us a nice summary there as well. I think what I've taken from this presentation is that at the heart of any digital transformation, it's still people, it's still about the training, the communication, getting them on board. And it sounds like with your next steps, the handovers and getting different teams involved is your next big piece of work with all that, isn't it? Okay. I've checked the question box. There's no questions from the public, but we did have a question between two of us. So I've got a question about if you were to do this project again, would you have done anything differently based on the learning that you've done, basically?
Yeah, definitely. I think one of the best learnings for us would be we hope that we know the limitations, the real limitations of the system early on. I think there was a certain assumption previously that because these are just simple changes, the system can accommodate it. Like what I mentioned, a simple change in font size, a simple change in column. We had the impression that, oh, that sounds easy. I think that should be done quite easily, but actually no. So if you are preparing for a system deployment like this, even the simplest question will be worth asking to the employer, because if we know that prior, at least we can set proper expectations as well to the clinical area that these are the things that this application can do for now, but we will try to explore how to improve it further.
Okay, thank you for that, Alderico. I'll pass on to Amna, and I'll warn you because she's done a big e-handle project as well in her trust, so she might have some more tricky questions than I have.
It's not really a tricky question. There's probably two parts of the question. So in terms of, I think you said you did the work divisionally, so you started in divisions in terms of rollout. So if you were to do it again, would you next time go for the big bang approach? Because there has been research where, you know, with an NHS staff team, they feel like they've got change fatigue now because you're always introducing new things to the work practices. And, you know, people are thinking, oh, another change, another change. Would you have done it differently, or would you have still gone with a small sort of rollout in one area and then transition from there, or big bang next time?
I think the difference with how we did it this time, that's why we went for the divisional kind of implementation, is because the process that we're replacing is very manual, using technically a Microsoft Word, not necessarily a separate electronic system. But I think if we go on our next deployment, I would very much happy to explore Big Bang, just so there's just one system that the staff use in the day. Because obviously, once we started using this system, if everyone is using the same system, it means that when the patient moves around as well, that information goes with them. As compared to having two different systems, where if we're just updating this system for this area, even if they move the patient to a different area, that information will not work through the other system. And I don't think it's very efficient to have the staff to actually utilize two different systems at the same time, because it can lead to error as well. So I think that the answer will be very much keen to explore the Big Bang on that secondary approach.
I think our audience need a bit of prompting with the questions, but the questions are flowing in now. So there's a message from Lisa. It's not a question, sorry. It's managing expectation very early on is key. So it's just to echo this. And then Aline O'Hare has a question. Do you use the handover with virtual ward handovers?
Not at the moment. Virtual ward has been excluded as a scope for the handover.
Okay. Thank you. And then Sheena Keatis, we've got a question from her, I think. How did you engage clinical teams with design? I think that's a question that's interesting.
Yeah. So previously we had a group. We call it I forgot the exact name of the group, but it's a group that actually we spoke with and co-designed the e-handover with. But in terms of design, it's mostly a question of what information you would like to go through the e-handover, because I don't think in terms of the UI itself, there's not much that we can do about it, if I can remember it correctly. So it's more of understanding what are the specific information, important information, that if transferred from one word to another, that information will remain relevant. So we've had different sessions. We've also had a trial ward, and I think that's one of the key to the success as well, because the trial ward who's using it, even if obviously it's just specific to their area at the moment, it doesn't really transfer over to a different area. They managed to provide really good feedback that we've used as a reference as well, and continue to design the application.
Okay. Thank you. And I've just been handed over a question here by Chris. The product is focused on nursing professions. That's right, isn't it? So what, sorry, they looked at the impact on other professions such as doctors or pharmacists maybe, or the wider MDT team?
Oh, sorry, can you say the question again, Hojan?
So what impact does this have on other professions apart from nursing? I think the question is.
Okay. Well, I think starting with the nursing profession itself, it made the handover process more streamlined, which means in terms of the information that we get, we are assured that it's relevant, it's timely, it's accurate. Some of our doctors actually have requested access to the handover as well, and that's true with some of our physiotherapy as well, and occupational therapist. So they've not been really using, because it's out of scope, they've not had full access to the application just yet. But that's the next step that we're exploring, how to ensure that they have participation with it, and if they have any input with it. But at the moment, that's still something that we're looking at.
Okay, so next steps.
Yeah.
All right. Thank you. Don't think there are any more questions. So I'll just say a big thank you for coming to this eMasterclass to present. And yeah, I'm sure I'll see you. If there's any more questions from the public, we'll just put them on the Futures website and we'll link it in, so the public can still engage. Maybe they're watching it on a recording later or on a different platform, if that's okay.
Fantastic. Well, thank you very much for having me today. Appreciate it.
All right, pleasure. All right. Shall I hand over to you, Anna?
Yeah. Okay. Hi everyone. So now we've got the University Hospitals Birmingham NHS Foundation Trust, who are going to speak to us about, firstly, they've got an in-house developed EPR system, and PICS is the Prescribing Information and Communication System. We've got 3 speakers. So there's Asif, who's the Advanced Clinical Pharmacist in Electronic Prescribing, Nilip, who is the Specialist Clinical Pharmacist in Antimicrobials, and Shakil, who is the PICS Drug Dictionary Analyst. And their talk is on vancomycin and gentamicin structured prescribing templates for initiation and intelligent decision support for UTI treatments in elderly and renal patients. So as a reminder, the question tab, please use that as you go along to put any questions you have in there so we can ask at the end of the presentation. I'm going to hand over to you guys now.
Thank you very much. And sorry guys, our intro is a lot more boring than our predecessor, who has far more exciting accolades than we do. Could you start us off on the first slide, please? Thank you. So we're just going to briefly talk to you about how we're trying to get antibiotics working in our electronic world. Flip on to the next slide, please. We work over at University Hospitals Birmingham NHS Foundation Trust. We're a multi-site hospital with 4 sites spread across the city of Birmingham, treating approximately 2.2 million patients each year, with a total capacity of around 2,700 beds. We've also got a few community sites and home care areas as well that we deal with. And we've had a system called PICS, which is an in-house system. Next slide, please. In-house developed electronic patient record, which started way back in the 90s with development in renal with a very catchy acronym known as RUMPS, that then spread out into liver with another catchy acronym called LUMPS, and then slowly spread out across the hospital and became our EPR of choice across the trust. It's grown exponentially since its first introduction way back in the 90s. It's a very clinical-led system with clinicians driving the developments that take place within the system. So it's a very in-house led, in-house developed, clinician-led, clinician-focused system. Next slide, please. And part of this allows us the opportunity to make antibiotic prescribing a little bit better. And some of the things we're going to be talking about today will hinge around the use of manual calculations versus utilizing a computer to do the computation for you, and trying to provide guidance to make the right choices. So a lot of with electronic prescribing systems is, I'm sure a lot of you have heard of the term alert fatigue and information overload. So a lot of the design that we try to implement tries to minimize the information overload and trying to provide the right information to the right people at the right time, which is very difficult sometimes. And it's very easy for people to ignore messages and prescribe things at light speed by ignoring a lot of the messages and warnings we provide. So we try to make life a little bit easier for them. Next slide, please. The first thing I'm going to start talking to you about is around aminoglycoside prescribing. So the manual process of aminoglycoside prescribing is we need to work out what the patient weight is and Cockcroft-Gault renal function, and then take that information and prescribe the dose according to some dosing tables, whether the patient's in AKI or not. The dosing tables and the procedure seems fairly simple. It's just like all you need is patient weight, put it into an equation, get a dose and prescribe it according to a simple table which you have to look up. Next slide, please. The weight part of it actually becomes a little bit more complicated. So for the weight prescribing, a prescriber in our system has to go to the observations, go to the height and weight section, determine if the BMI is greater than or less than 30. If it's less than 30, then you've got to put the actual weight into the calculation. If it's greater than or equal to 30, we have to then work out what the ideal body weight should be, which means clicking on an external link, putting some information into an external calculator to work out the weight, then using that to work out the actual dose, going back via the table to work out the renal function. And all this sort of takes bits of information from different places and just makes prescribing a little bit slower than it should be and isn't as easy as it could be. Next slide, please. So the whole idea behind what we did with aminoglycoside prescribing was the aim of trying to help the doctor navigate the maze of prescribing an aminoglycoside. Aminoglycosides, drug dosing isn't that complicated until you start bringing in renal function and realizing the toxicity windows and the therapeutic indexes are quite narrow. And the prescribing then becomes a little bit more higher risk. So what our aims were to leverage the EPR and the electronic information we had to try and make life easier. Ask the doctor some questions, gather the information you can gather that we can reliably gather from different parts of the system to save them having to click on all those different parts of the system and having to do the calculation manually. And we created what I would term a simple order set. Simple order set that for gentamicin was about 300 lines on Excel. For vancomycin was about 700 odd lines on Excel and branches that we had to calculate. But from a front-end user, you'd never realize that took place. But it was an interesting journey to try and get that done. But the end point was to simplify the process for the prescribers and to make prescribing safer. So what do we do? Next slide, please. First of all, we put in some guidance to the prescriber. If a prescriber goes to try and prescribe gentamicin, we slightly nudge them towards using the gentamicin calculator and the structure via the system. And this is a screenshot from our system, the PIC system. If they prescribe gentamicin, it takes them to a window to ask them if they want to prescribe the gentamicin via structured prescription. Obviously, we can't prompt all prescriptions to go via structured prescription because you're going to need to make dose adjustments, one-off stat doses for surgery and possibly other forms that aren't injection that you might still need to prescribe gentamicin for. So we can't completely block it and force a prescriber into it, but we can try and guide them to make the right choice. Next slide, please. We asked the prescriber a few questions. So at the top, there's a couple of screenshots of some of the questions we asked them. Is the patient on dialysis or not on dialysis? Because that's information I can't reliably gather from the EPR. We can look at blood results, but if you're on hemodialysis, as you know, the blood results go up and down. We can rely on classifications, but then if patients are on hemodialysis temporarily, we can't rely on those classifications being taken off properly. So we just asked the question. It's a very simple question. We asked the prescribers if the patient has certain conditions, like if they have myasthenia, cystic fibrosis, or if they're pregnant or the pediatric, at which point the system will take them to a block and say, you need to seek further advice because this is beyond the scope of this structure, and this is a very specialist type of initiation. We asked them if they have ascites or burns, which takes them through to a different algorithm. And if the patient doesn't, or you answer the questions that don't take you through to a block, you're presented with the dose. What the system does in the background is it looks at the patient's weight. If there's no weight recording recently, it won't allow them to proceed. If there's a recent weight in there, it will take that weight, work out whether they're obese, put it into the relevant calculators, do all the thing and come up with a dose and frequency as per our guidelines. So basically it takes out all the faff of the prescribing for the prescriber. Just underneath the dose part of the window, there's a little window that says what dose has been recommended. 3 milligram per kilo of ideal body weight, because this patient ended up becoming obese. So the prescriber can kind of see what calculation was taking place in the background. They fill out the boxes, say whether they want an additional one-off, hit the button, and the prescription lives there. And we decided to set a duration of 3 days after much debate with many different stakeholders. 3 days was there so that the prescription doesn't end inadvertently, especially if we have a prescription done on a Friday, the patient's not left without an antimicrobial over the weekend. The system will also prompt the printout of lab order comms and blood levels for gentamicin at the right times as well. So we're making sure that the blood levels are taken at the right times. And then the results are fed back into pics, which are visible there for prescribers to then adjust dosing if necessary. Next slide, please. Does it actually help?
Thank you, Asif. So initially, we have a gentamicin structure prescription, which was developed back in 2016. So at that point, the structure prescription developed, as Asif mentioned earlier, the reason for it, because we are not getting right frequency, we are not getting right doses. So it came into light that there was quite a lot of prescription errors happening. So we have decided back in those days to create or develop a gentamicin structure prescription. At that point, we had done the audit following the development of gentamicin structure prescription, and we noted that there was 85% of compliance following the audit by one of our junior pharmacists at the trust at that point. So we were quite happy with that at that point, that gentamicin structure prescription was working how it should be working. So we are quite happy with that. But in early May 2013, so this year, we have decided to change our antimicrobial guidelines. So we changed, main change was the infective endocarditis guidelines, which was part of our gentamicin structure prescription. And we have decided to move from 1 milligram per kilogram twice a day dose to 3 milligram per kilogram once a day dose. So that was a quite big change. And as Asif mentioned, we have done quite a lot work in the background for the developer to develop this new structure prescription. So between May 2013, we decided to switch off our old structure prescription for the development of the new structure prescription. So we had about 3 months window where the structure prescription was completely cut off from the system. and we are proposing all the clinicians to use a manual calculator. Basically, as Asif mentioned, we need to go to different tabs to calculate the gentamicin dose. And following that 3 months period, we wanted to know whether all the prescription were correctly prescribed, all the dose was correctly prescribed, and we noted that. I'll give you some time to think about how much that was a difference. If you want to put in a chat or something like that to see how big was the gap when the structured prescription was turned off to they're using the manual calculator. I'll give you about 30 seconds to see whether you want to put any comments on there, and you can see the results after 30 seconds.
Yeah, pop into chat if you want to guess the percentage of compliance with gentamicin correct dosing after you switched off the structured prescription. Throw anything into the chat. It'd be interesting to see what you think.
Let's see.
5 to 10%.
40%.
Cool.
Okay, thank you. So if you is the next slide, is the next slide, please? Yeah. So here you can see there was a 85% non-compliance to our guidelines when the prescription gentamicin structured prescription was turned off for, I think, roughly 3 months, I would say. It's a big change, and this was audited by 2 of our students at the time from University of Birmingham, and they did the audit for us, and we noted that there was a non-compliant to 85%. Since then, we haven't done the re-audit, but that re-audit is underway, and we would like to see how much compliance is there since the new structure was gone live. So hopefully in next 3 to 4 months time, we'll have that data in front of us as well to see whether there's more compliance and the new structure prescription, because there was few questions added in the new structure prescription, which were not included in the previous one. So there was quite a good reflection to see that structure prescription for gentamicin and vancomycin are working for us. Next slide, please. So this is another thing we did recently about the intelligent decision support for UTI treatment in elderly and renal patients. So this was a part of our CQueen we signed up for last year. It was a UTI CQueen. Initially, we noted that there was a non-compliance to our UTI guidelines. So I would say about 60% of patients were prescribed an antimicrobial, which was not part of our guidelines at that point. We already had that data in front of us before we started our CQueen, UTI CQueen last year. So there was some brains from IDA came from a few of our colleagues and a PICS colleague, and Sakil, which is part of the PICS analyst team. He was part of it, and we decided to do something about it. How we can improve our antimicrobial, particularly for UTI, to improve the compliance, because it was quite poor at that point. They were prescribing an incorrect antimicrobial, incorrect duration, incorrect dosing. So there's quite a worrying sign for us at that point. So it was kind of MDT-led discussion happened with digital team and antimicrobial team, and we have decided to implement the intelligent disease support tool. Shakil will go into detail. Hand over to you, Sakil. Next slide, please.
Thank you, Nilab. So here we have a screenshot, the updated guidance for the UTI treatment. The challenge is, how do we take the updated guidance and then align it to the electronic system? So the easiest method would be just adding all this information in the form of messages to each drug. But the drawback is, by adding these messages, it results in alert fatigue, as Asif alluded to earlier. Next slide, please. So for this reason, we decided to change our approach and use what we had in our system the existing functionality and use it in a smarter manner to inform our users of the updated guidance. So this involved using redirects from trimethoprim to nitrofurantoin because of the increasing resistance of trimethoprim. And then other things such as specific messaging that we can have for the individual patients based on EGFR, the gender, the grade of the prescriber, and the age of the patient. Next slide, please. So best way to demonstrate this is by using an example. So we have patient A, male, EGFR 45 as an example. So the preferred choice is nitrofurantoin, and that's prescribed as per normal. However, there is, next slide, please. However, users may not be aware of the guidance and they may go to trimethoprim first. So the aim of the redirect is to nudge and guide the user to the appropriate drug. In the window, it explains the reason for being redirected to nitrofurantoin, and it also has a link to that message to the current antimicrobial guidelines for further information for the prescriber. Next slide, please. But it is still possible to prescribe trimethoprim by the user signing off the message. And what that involves is adding in their password to acknowledge that they understand the message. And on the right-hand side, you've got the prescription window. And at the bottom, it will state the EGFR value, which is 45, and it will actually tell you that would you consider prescribing nitrofurantoin 100 milligrams twice daily for 7 days for male patients. So not only does it tell you the course length, it would also tell you the gender and the course length that's appropriate for them. Next slide, please. In the same situation, if patient A was female with the same EGFR, nitrofurantoin is still the preferred choice, but only for non-pregnant females. This time, the message is slightly different, and it will be more appropriate for the female gender. So it would be 100 milligram twice daily for 3 days in a non-pregnant female. Next slide, please. So we could also restrict the user based on their grade. So next slide. So patient B, male, EGFR 35, the preferred choice under the guidance, it's trimethoprim. As you can see on the left screenshot, if it was a junior doctor, they wouldn't be able to proceed further with the prescription, and they would have to refer to a senior. But if it was a senior doctor, they're presented with the EGFR, and again, it will state, consider prescribing trimethoprim, 200 milligram twice daily for 7 days for male patients. And another message would also, underneath it will tell you it is contraindicated for patients under 45. Next slide, please. The other change we made was based on urine dipstick messaging, which is based on the patient's age. Next slide, please. So, next slide, please. So if the patient is under 62, it's okay to use urine dipstick testing, but if the patient is above 65, the message would be shown, urine dipstick is not recommended in patients above 65. Next slide, please. We also placed in prescription defaults where the prescription lengths are pre-populated in the field of the prescription window, and this is based on the patient's gender. So if it was a male, it would be 1 week, and for a female, it would be 3 days. Next slide, please. Up to you, Nadat.
Thank you. Right, so so what happened after the pre-implementation of this set orders and post-implementation of orders? As we already alluded earlier, that pre-implementation we have very poor compliance towards antimicrobial guidelines for the UTI indications. Post-implication, you can already see is 95% compliance, and we were quite happy with that. Other 5%, give and take, there may be compliance, but we don't know we don't have that data at the minute. But 95% compliance towards our guidelines for the UTI, that's what we want to achieve. And I think that we will achieve just doing a very simple tweak to our digital system. And yeah, we kind of we passed the sequin in flying colors with that. So I think simple preset or kind of pre-planning with the digital digital analysis of people, I think we managed to achieve our goal quite effectively. So yeah, and that's us done. Thank you.
Thank you, Asif, Nilit, and Shakil. That was really interesting, and we can see there the benefits of using these structured sets for prescribing antimicrobials. There's actually been a lot of questions in the chat, so I'm going to start with the first question. However, if we don't get a chance to get through all the questions, could you answer them later and we can put them on the Futures website? So I'm going to start with the first. Oh, he's gone. Sorry, I've got technical issues here. Some of them, the team's already answered. Okay, so we're just going to scroll down to the first one that hasn't answered. I think you've impressed the audience so much that OneTrust wants to see a demo of you guys because they are retendering their EP system. So that's quite good. We'll take 10% commission.
Only 10, I'm impressed.
So there's a question here from Glenn. Are you concerned that this will de-skill prescribers? 85% non-compliance suggests this is potentially an issue. Is the expectation that clinicians second check the calculated/prescribed dose suggested by the structured prescription? And does the clinician take overall responsibility for the accuracy of the prescribing?
Very good question. De-skilling versus patient safety is one thing that we've kind of had a bit of a debate about. It's if 85% of prescriptions are wrong, we're putting patients at risk. I'd rather get more prescriptions right and slightly de-skill the prescribers for them to be educated through a different route. Because at the point of us intervening and correcting a problem, it might be too late by then. I'm sure you probably all heard of the deafness, etc., and renal problems caused by poor aminoglycoside glycoside use. So it's one we have discussed in great detail. And if you're expecting the clinician to double check it, I don't think that would ever happen either. I mean, practically, it's a great idea, but practically I can't ever see that taking place. I know some of our pharmacists do, and I know the system works because we sometimes have pharmacists coming up and challenging the prescription, and then I correct them because they've made a mistake in the calculation themselves. So it is a bit of a complicated prescription. It's become a little bit easier with this latest iteration of guidelines, but we have had that where pharmacists have gone away and done the double check and then come back and gone, actually, no, we're wrong.
So the system is taking responsibility for the accuracy then of the prescribing.
Yeah, so this is part of our accreditation. So we're getting accredited with a, and the word has completely eluded me. We're getting MHRA digital device, so that will then be part of the license criteria. Would be the system is responsible, we're responsible rather than the clinician. The clinician is making their prescription, and if they're getting 15% right before and now they're getting 85% right, hopefully we're doing something right somewhere. But we're getting accredited for MHRA license, so the system will be taking responsibility.
Okay, great. So there's another question from Richard. Do you use other workflows to direct prescribing, such as prescribing an order set for specific conditions? For example, prescribing a set of antimicrobials for CAP?
Yes, so that's a very interesting question. We kind of do. Though what we found is using order sets for normal antimicrobial prescribing, because we have to ask people questions, they don't like to use the clicks and go through the questions and go to the end when the consultant might have just told them to prescribe comoxiclav for some CAP. So a lot of the time people will use just the normal prescribing. But implementing an order set, we're trying to look at different ways to nudge people in the right way. But also one thing we found was the introduction of informatics and data collection. Because we've got electronic prescribing, you can collect data. And we have quite a good informatics team who work with junior doctors and will plot the amount of prescriptions done within an order set for antimicrobials versus the number of prescriptions done outside of an order set, and can plot that against their peers. And what they do is every so often they'll pull out the outliers, the ones who are really good and the ones who are really bad, and bring them into a junior doctor clinic and discuss that with them. And for the ones who are really good, we'll find out why it is they do what they do and try and take that behavior to the ones who might need nudging in the right direction.
Yeah, there's one more question from Mohini. For the antibiotic prescriptions with a preset duration, have you found an issue where prescriptions are automatically stopping even if there's a clinical need to continue, particularly over the weekends, etc.?
Yeah, we do have that. So we've got some things in place that warns a prescriber a few days before it's due to end to say, please check, this is about to finish, make sure you're carrying it on. As I'm sure you can imagine, days often get missed. So we've had many debates, and I think I might have answered this on a colleague's question about soft stops versus hard stops. We've kind of gone down the hard stop route, and it is continuing education and prompting, but there are occasional incidences where it does happen, but they've become less and less as the years have gone on, because we're just battering on the message to prescribers at every stage that we can to make sure that these don't fall off the system, and also utilizing nurses and pharmacists and our other colleagues to also keep that message going through to prescribers. So it's still a problem, but less of a problem than it used to be.
Okay, thank you for that. If there is any questions that are left in the questions box, Asif and his team will hopefully answer them. We can put them on the Futures website, yeah, if there's anything that has been missed. Thank you for sharing your presentation with us about how you've developed your in-house program for antimicrobials. In terms of the next masterclass, everyone, so the next one is on Wednesday, the 13th of December. So please, if you scan the QR code to register now for the next session. We'd also like to ask if you've got any ideas for future topics or feedback or volunteers to present at a future session, please could you email Sarah Black and she will then arrange and let you know the upcoming dates for the masterclasses. The certificate will be available at the end of the session. It'll be sent out with the recording to you all in a few hours, so you'll have your certificate of attendance. And also, can you please make sure you join the Medicines Optimisation and Digital Learning NHS Futures by emailing again Sarah. We look forward to seeing you next month.
Yeah, thank you all for joining. I think I quite enjoyed the session today and looking forward to our next session on the 13th of December. Thank you, everyone. Thank you. Bye. Enjoy the rest of your day.
Bye.
Bye.